Hello, everyone. Welcome to the Roundtable. We'll give everyone just a few more minutes, or one more minute, and then we'll get started. Ticked over to 11 o'clock my time. So, welcome. Thank you so much for joining our Roundtable today. Well, we're excited to have you here, and we have a great list of panelists. And for our learning objectives today, we are going to be going through some tricky topics. And we'll have Vanessa, our CDI manager, talk about that. We have three panelists, and then Allison will be talking about clinical validation. And just a quick disclaimer, the information presented today is just our experience. And even though we've researched everything and reviewed for accuracy, we don't accept any liability or errors for admission. It's just some information for everyone. And just many of you know about you E4, and we're just so thankful that you've joined us, and many of you we get a chance to work with. And we're a company that's been established since 2004. We have 400 clients across the country, and many of you are customers, and thank you for that. And we're growing every day. We have 1,000 team members, and we're three companies combined of E4, Intellis, and eCatalyst. Our expert lineup, super excited about these three lovely ladies that you'll be hearing from a little bit later in our presentation. But we have Debbie and Pyle and Tanya. Thank you all for joining. And I am going to turn it over to Vanessa as she starts some of the content with the selection of principal diagnosis.
Hello, everyone. We're going to be talking a little bit today about the principal diagnosis, and I know this is information that many of you know. So the principal diagnosis, as defined by the UHDDS, is defined as a condition established after study to be chiefly responsible for the admission of patient to the hospital for care. Next one, Stacy, please.
Just a little slow. I'm sorry. It's coming. There you
No
go.
worries. So this is a kind of a list of things that in the official guidelines that guide you on principal diagnosis selection. And I won't go into these like in detail, but signs and symptoms sometimes can be defined as, a principal diagnosis depending on what's going on with a patient, two or more interrelated conditions, and of course, two or more diagnoses that equally meet the definition for principal. And then also two or more comparative and contrasting conditions. And, there's many situations where your original treatment plan doesn't get carried out for whatever reason. Also complications of surgery, and of course, uncertain diagnoses that sometimes established throughout the stay and always at times don't get defined until discharge. Next slide, please. The coding hierarchy, which, we all have to follow, is when there's a discrepancy, we follow this. So you'll start with the conventions first, your guidelines, and then the clinics. So the conventions are always going to take precedence over guidelines and clinics. And this is just a little bit of a visual to help you with that. Sorry, Stacey, interrelated and competing diagnoses. And I know many of you are familiar with this, so we'll talk a little bit about this. This is just from the official coding guidelines, section 2B, where there are two or more interrelated conditions that each are potentially meeting the definition of principal. As you know, many times we see this and one can be sequenced first over the other. So it's basically based on the of admission. Often we like to say what bought the bed, right? So that's a term we'll hear a lot. And then also when you have two or more that equally meet the definition for principal, which can, doesn't always happen, but sometimes it does happen. We like to always look at the resources and treatment expended. This is a little bit of a process map on how I like to work through when I'm deciding what the principal diagnosis is. Look closely on each diagnosis, what actually necessitated the inpatient admission. If there is only one of those that necessitated inpatient admission, then you, of course, will select that one as principal diagnosis. If both look like they're responsible for inpatient admission, then you'll kind of review the treatment provided and the resources provided and determine which one required more resources. And based on that, you would select the principal diagnosis. In situations where equal resources are expended on both, then either could be selected. Many times referring to the coding rules or facility policies is helpful in helping guide this. Some facilities look at other things on deciding how they sequence that. Many times these are the most complex cases to look at. So we'll go to the next one. This is just a bit of a scenario. The patient came in with shortness of breath and chest pain. Prior to the admission, the patient had been treated as for outpatient basis with PO antibiotics. Came in, X-ray indicated he had bilateral lower lobe infiltrates, but also had a CT revealing a right pulmonary embolism. Oxygen saturations were 88 and improved to 91 after 2 liters of O2 therapy. The HMP is saying acute PE and treatment included the IV Levaquin, the O2 at 2 liters, the IV heparin, and then he was discharged on Eliquis. In this situation, what would be the principal diagnosis? Well, both of these either could be. A lot of times it just depends on what, your facility guidelines, whether it's interrelated or competed, either diagnosis in this situation could be chosen. We're going to talk a little bit about signs and symptoms. So many cases, the question is, can signs and symptoms be coded as a principal diagnosis? If there's no related condition that's identified, for instance, if there's a symptom that is a reason for encounter, one of the symptoms I like to think of is dizziness, because many times they may not be able to identify the underlying cause of dizziness. And, we often, when we see that R code, we tend to think, oh, no, I don't want it to be an R code. And there are cases where you really can't change that. Presenting signs and symptoms are, coming and going, and you can't get to a definitive diagnosis. If the patient is referred elsewhere for additional study or treatment before you can get a definitive diagnosis, and then a more precise diagnosis cannot be made for any other reason, which is probably very similar to the one at the top, but these are some of the reasons listed in the guidelines for sequencing signs and symptoms as principal. Also, if the symptoms been treated in outpatient setting without additional workup and you couldn't arrive at a more definitive diagnosis, for instance, if a patient's in the office with a provider and he's got altered mental status, and the provider decides to send him to the hospital for inpatient admission, and a more further workup has been done, but maybe they can't determine what this particular specific diagnosis is, the patient may still end up discharged with altered mental status, just depends on the workup. And also a provisional diagnosis of sign and symptom is made for the patient. And the one on this one, I like to think of your AMA patients. Many times, they'll come in and they won't allow themselves to stay for whatever reason. They'll want to be discharged. So maybe they came in with, weakness, and that could not be further worked up because they decided to leave the hospital. So that would be a case where you would sequence sign and symptom as principal, and also a residual late effect. This is a little bit of a situation, problematic signs and symptoms. These, of course, are hypothetical situations. A patient comes in with paleness, lightheadedness, and diaphoresis. The provider is only hemoglobin of 7.3, requiring 2 units of packed red cells, and also noting from the EGD that the patient has GI bleeding. However, the provider is only dizziness. However, the patient does have a history of anemia. In this particular situation, our DRG would be 149, which is, if we go to the next slide, I'll talk a little bit more about what happens when we query. So our opportunity here is to ask for the underlying cause of the dizziness and to clarify regarding the low hemoglobin. So after the query was sent, the provider comes back and says dizziness is secondary to GI bleeding and noted to have acute blood loss anemia. In this case, there's a potential increase for GMLOS and reimbursement. So initially, the patient starts off with a DRG of 149 and a relative weight of 0.7475. And then after, lands in DRG 378 with a relative weight of 0.9859. This is an increase from 1.9 to 2.9. So we're increasing the GMLOS by 1, and we're increasing the relative weight by 2.384. So in this situation, Many times I know there's not always a focus on the GMLOS, but the GMLOS is very helpful. It's based on national data and benchmarking, and it helps define for case managers and utilization review what is kind of the assigned length of stay expected for that patient. And it also could be a trigger for potential audits if the patient stays much less than expected from that geometric length of stay. So it is something to look at. I worked at one facility once where we actually looked closely at those in huddles, and it was very helpful both for CDI and case management. This is just another, again, hypothetical scenario where the patient comes in with shortness of breath and difficulty speaking in sentences and increased respiratory rate. The patient is on home O2, 2 liters, comes in with a SAT of 87, improving to 90 after placing the patient on O2, 4 liters, remains on that throughout the stay, and the provider is respiratory distress from day 1 to day 3. So he's not being really specific. In this scenario, the DRG assigned would be 204, which would be respiratory signs and symptoms. And then the next slide will talk a little bit more about what we do. Our query opportunity here is to ask for the underlying cause of respiratory distress, clarify the cause of distress based on his history. And so when the provider responded back, they said acute on chronic respiratory failure, moving your DRG from 204 to 189, increasing your GMLOS from 2.1 to 3.5, and increasing your relative weight by 4.4 to 66. So this was a big move too. Again, their focus on GMLOS is very helpful because it allows more resources and more time to be given to the patient for like a more adequate workup. That's why our job as CDI is so important. And I like to cover this part because as CDS, we do so many like key things that are so critical for so many organizations. But in the role of determining your PDX, you're trying to determine the condition responsible for admission. You're trying to look at the inconsistencies and ambiguity to see if there are missing links to symptoms that are presented. And if needed, you will query. I like to look at it from the perspective of how important this is, not only for quality, but for facilities, for reimbursement reasons, but also for families. And I think of this from the standpoint of if I had a family member, whether it be my child or extended family member, and an inappropriate diagnosis was noted, I want to make sure that appropriate diagnosis is in the record and that's getting filed with in the appropriate EMR for my family member. Things to consider when we're assigning the principal diagnosis is what is our possible known cause of symptoms? What is our focus and resources and treatment expended for the inpatient stay? Has the provider been given adequate time for a workup? Is it day 2 and we possibly need to give the provider a little more time to work up the patient for a sign and symptom? Or are we too early in the stay to ask the question to allow for pertinent query options? Also looking closely at reports such as labs, nursing assessment, ancillary reports, and diagnostic reports. Also, sometimes I think this can be overlooked is your ER notes. If the provider in the ED has mentioned some potential reason for admission and maybe the person admitting the patient didn't mention that, but that clinically is supported, that is key in providing information in your query if needed. Also, if your EMR has the functionality to do keyword searches, that can be very beneficial when you're looking for appropriate diagnoses, such as, malnutrition, sepsis, AKI, ATN, things of that nature. And was the presenting sign and symptom potentially related to a recent procedure? If so, look more closely at how that procedure and what happened and what the sign and symptom is. Can the sign and symptom be more clearly linked to a diagnosis? And the last one I feel like we forget a lot is to review the case for transition from observation to inpatient for reason for admission, because sometimes the reason for observation and inpatient are very different. I won't go over this in detail, but just these are potential R codes that we can look at as query opportunities. If we see these R codes, this of course is not an all-inclusive list, but these are some of the ones that came to mind that often when you see those, look for like an underlying etiology or cause for that particular sign and symptom. And the value of appropriate PDX assignment It's key to have, for accurate reimbursement purposes, to assign your appropriate GMLOS, and to also reduce the time spent retrospectively, because many times when you're looking at this retrospectively, you may spend excessive time looking at that on the back end if you haven't assigned that PDX appropriately in the beginning. And it also helps with denial mitigation with payers, because if you have that assigned appropriately, it helps reduce the risk and kind of protect the integrity of the record. It will also help with streamlining reconciliation process. And last but not least is to give to give us peace of mind. And the value of this is so important as a CDS, and we at E4 feel like it's very important and key and critical for your hospital and your organization.
Wonderful. Thank you so much, Vanessa. I just remember, being a CDS, and those principal diagnosis and those signs and symptoms are really tricky, and trying to really kind of move them out if we can, and making sure that it's compliant. So thank you for sharing that with you. I hope our audience got a couple pieces of nuggets, or at least some reminders of that. So now we're going to start with our first panelist, and I am excited to welcome Pyle. And Pyle, if you want to just describe your current role and responsibilities within your organization.
Absolutely. And I just want to say Vanessa's presentation right before was excellent. Covered everything that we really look for in a principal diagnosis. So thank you, Vanessa, for sharing. So as the director of hospital coding education, I'm responsible for strategic planning, development of comprehensive educational programs for hospital-based coding. So that's inclusive of inpatient, outpatient within Montefiore Medical Center. I assess the learning needs and ensure that our educational content matches the current compliance standards, right? Reimbursement methodologies, that includes APCs, that's really for outpatient, MSDRGs, your APR-DRGs, including New York APR. And of course, you want to stay on top of the evolving healthcare trends, right? You want to make sure that the team is ready with the constant changes in guidelines and payer reimbursement. You want to make sure the team is ready and able to get that reimbursement for the facility. I collaborate very closely with our counterparts in HIM, quality and coding, and CDI to ensure that our coding education continues to align with our organizational goals. Aside from coding education, I serve as a subject matter expert in our organization for anything related to software updates or anything really coding specific that would impact revenue cycle. Overall, the goal is to really ensure that our educational program supports both individual professional growth and development, and organizational performance targets are met.
Thank you. You've got a big job there, right? You're doing your hands in a lot of different things. That's wonderful, and they're lucky to have you in your organization. So from your role, how do you approach or educate your teams on principal diagnosis selection when there's those interrelated conditions, hierarchical complexities, or those competing clinical diagnoses? Just from your day-to-day work, how would you answer that?
Absolutely. So the way I approach principal diagnosis, and anyone else that we train, whether it's CDI or HIM, kind of goes through following a structured guideline-driven approach, right? You want to make sure that you're following what the patient came in for, whether it was a sign and symptom like Vanessa stated earlier, or it was an actual diagnosis that was established at the beginning of the stay. You want to follow that till the end of it and make sure that, the clinical context matches the sequencing of the events and the conditions that required the most intensive treatment is all captured in the code set, right? You want to follow the coding instructions, such as the code first rule. That will always help with your principal diagnosis, because you don't want to have something that isn't allowed by CMS as your principal diagnosis. That would impact your reimbursement and also open us up for an audit. So that's one of the main things that you want to look at. And then another thing would be looking at those hierarchy diagnoses, right? When a patient comes in with an HIV with an opportunistic infection, right? So if you are looking at the guideline-driven approach, if you're following that, you would know that HIV would be sequenced first, then right? Another scenario where the patient has an HIV and they have a hip fracture. If you aren't aware of the guidelines, you're going to continue to put HIV as the principal diagnosis and the hip fracture as a secondary, which will drive it to the wrong DRG. The coding guideline would state that you pick the hip fracture as the principal, followed by the HIV diagnosis. And again, collaboration with CDI is very important. You have to have that robust relationship. So that way we're able to, educate the providers and making sure that they're, your slide just dropped.
Yep, keep going for a second. I've just got to switch something up really quick. So
No
keep going,
problem.
Paya. Sorry.
That's okay, no worries. So you want to make sure that that collaboration is happening and it's happening at a robust way possible, right? So that way together we're able to educate the providers and make sure that they're the clinical scenarios, the clinical evidence that the patient is undergoing, so we could get the optimal reimbursement, A, and B, we want to make sure the clinical picture matches what our code set is going to the payer.
Great, thank you so much. Just give me a second. I apologize.
It's okay.
I'm going to share that again. Okay, that lot of great information in there. And I love how you talk about collaboration and really that engagement. Can you share any best practices or tools that help you or your team support in that decision making process?
Absolutely. So one of the the first practice in play should be constant adherence to the ICD-10 coding guidelines, right? To any encounter that we come across, we want to make sure that there's consistency and we're following that coding guidelines throughout the stay, throughout patient encounters that we see. We should also be using the coding clinics, right, for a backup, if you will, for those coding those complex cases, right? Coding clinic is a very good reference to have, especially with surgical cases and certain diagnoses. And personally, I found coding clinic to be really, really effective during the COVID time when guidelines were constantly changing, and that we depended on grants, we depended on reimbursement to make sure that we were able to treat our patient effectively and show the true clinical picture of the patient. And again, I can't say this enough. You have to have that robust collaboration with CDI, with HIM, as well as providers. So that way you're able to clarify those ambiguous and you're able to use that as a tool so that for future reference, they could be educated and we could have better at hand. And as far as oh, sorry.
Go ahead. I'm so sorry.
No. As far as the audit tools are concerned, right? For retrospective cases, you could review cases, you could identify discrepancies and provide feedback to the coding staff, and also use those opportunities to kind of in partnership with CDI, so those opportunities are captured upfront. So it serves as both cases, in retrospective as well as concurrent.
And I do really like that where, as an auditing thing, right? Like to evaluate, and I do a lot of chart pulls for audits and, I do look through those symptoms, right? To see like those ones that Vanessa had talked about, like, is there an opportunity there? So thank you for that. And then just as we wrap up, and so insightful, Kyle, I just appreciate you sharing with you. But any specific things before Allison's going to transition to clinical validation? Any tips or specific things that your team looks for that as we transition over to Allison?
Absolutely. So you have to make sure that the clinical indicators are part of coding as well as for CDI. CDI is already clinicians, right? They are already aware of the clinical indicators that match disease processes. For coding side, you have to make sure that the clinical background is also given to them, where they're able to recognize the signs and symptoms and appropriately query the provider, right? So that we can get that diagnosis as part of our code set. And it would, from a coding and reimbursement perspective, the revised changes the DRG to a more higher weight, right? From a perspective itself, it maintains the integrity. And it also leads to accurate quality metrics and risk adjustment profiles. So I think knowing your clinical indicators and being up to date with disease processes will help in getting those clinical validity queries.
Great. Thank you so much. As you can all probably tell, I'm having some technical difficulties, so I apologize for that. I am going to thank you so much. Those are all so insightful. I hope you all find those insightful. Thank you so much for sharing. I'm going to turn it over to Allison, and I'll let Allison get started, and I will get the PowerPoint up in just a minute, but Allison's going to talk to us a little bit about clinical validation.
Yeah, and thank you, Kyle, Vanessa, and Stacy. And clinical validation is such a big topic. We could really spend an hour or more talking about it. So I'm going to try and consolidate that so we have time to have a discussion with our roundtable panelists. But I'd like to begin our conversation around clinically validating high-risk diagnoses by first providing a brief overview of clinical validation. So while this concept is not new to CDI, it really has gained increasing attention and importance over the years. And actually, when I interview CDSs, I always ask them if they have experience with leading clinical validity queries. And oftentimes they respond that it's their most common query left. And when we think about clinical validation, as many of you are aware, there are several respected sources, including ACTIS and AHIMA, who have published guidance on this topic, and a few of which we'll talk about in today's discussion. So the term clinical validation was formally introduced by CMS in its 2011 Recovery Auditor Scope of Work. And then most recently, AHIMA's 2023 practice brief update that defines clinical validation as a distinct process of a clinical review of a case to really determine whether the patient truly has the conditions that are diagnosed. So sounds easy in theory, but really a complex process. And clinical validation matters as in the early days of CDI, the focus was primarily on capturing additional diagnoses or improving specificity for coding accuracy. However, as CDI has evolved, particularly in response to increasing quality, reporting requirements, value-based care incentives combined with mitigating denials concurrently, the emphasis has really switched. And today, ensuring the validity of it has become just as critical as ensuring its completeness. And as a result, clinical validation has emerged as a key best practice across the industry. The updated AHIMA practice brief identifies several situations where issuing a clinical validity query may be warranted. And these are include, but not limited to really 4 examples that we have on the screen here. And these include a diagnosis that lacks clinical indicators that are generally accepted by the medical community, or a diagnosis appears to no longer be valid, but does not confirm whether that condition was ruled out, eliminated, or resolved, or an uncertain diagnosis has been copy pasted or carried forward from the H&P to subsequent, including the discharge, or a condition is present, but the patient exhibits a atypical clinical presentation and further clarification is really needed. So as we think about clinically validating high-risk diagnoses, clinical support is essential to the clinical validation process, and we'll talk about that on the next couple slides. However, it's equally important to ensure that each diagnosis meets the criteria for being reportable. And fortunately, the official coding guidelines do provide clear direction on this matter, specifically in Section 3 of reporting additional diagnoses. So that guideline tells us that other diagnoses are conditions that affect patient care by requiring one or more of the following here on the screen. So clinical evaluation, therapeutic treatment, diagnostic procedures, extend the length of the hospital stay, or increasing nursing care or monitoring. And this is also in alignment with UHDDS, as they define other diagnoses as all conditions that coexist at the time of admission, develop subsequently, or affect the treatment received and or length of the stay. And then the UHDDS also notes that conditions related to a previous episode of care that have no impact on the current stay should really be excluded. So when you're conducting a clinical validation review, any reported or secondary diagnosis really needs to meet one of these criteria to be considered valid and reportable. So following a thorough review of thousands of CDI records from across organizations across the country, our team identified the most common clinical validation query opportunities, which consistently centered around 5 diagnoses, and these included AKI, sepsis, a type 2 MI, acute hypoxic respiratory failure, and metabolic encephalopathy. So when we did our audits, while malnutrition did not appear in our top 5 most frequently queried diagnoses for clinical validity, it does remain a high-risk diagnosis and is worth highlighting. Meeting Aspen criteria for malnutrition can be really challenging in the absence of a registered dietitian consultation. So I think over time, CDSs have become increasingly vigilant about identifying and querying malnutrition when appropriate, which may explain its lower frequency in our recent audit findings. These diagnoses are considered high risk, and diagnoses to keep in mind as you review and clinically validate accounts for several reasons. So first being their frequent occurrence in the inpatient setting and their potential impact on reimbursement and audit vulnerability. So 4 out of the 5 of our most common diagnoses identified are MCCs. So that classification is going to lead to assignment to the highest weighted DRG within a triplet or a bundle. And then additionally, conditions like sepsis can significantly influence principal diagnosis selection, which directly impacts the base DRG and overall case reimbursement. And for this reason, accurate and clinical validation of these diagnoses are really essential, not only for coding accuracy, but also for financial integrity and compliance. So we reviewed the 4 common scenarios AHIMA illustrated for issuing a clinical validity query as outlined on the slide. There we go. So let's switch our focus to what the clinical validation review process looks like for some of those common high-risk diagnoses. And I'm going to use AKI as our example. So really, I think of this as like a 3-step process when I'm clinically validating high-risk diagnoses. So step 1, you want to apply organizational policies and diagnostic criteria. So first and foremost, it's essential to understand and apply your facility-specific policies or clinical criteria that your organizations have in place. So for the purposes of our discussion, we'll reference some generally accepted clinical guidelines, but always defer to whatever standards are established at your organization when you're conducting your reviews. The second step is to conduct a comprehensive record review. So when you're evaluating whether clinical evidence supports a diagnosis, it's really critical that you review the entire medical record. And so that includes looking for laboratory results, imaging, reviewing the medication administration record, vital signs, ancillary provider notes, assessments, etc. That comprehensive approach is going to ensure that you're applying the appropriate diagnostic criteria accurately and in the context of that patient's stay. And then the third step is really to confirm alignment with coding guidelines. So you want to make sure that there's sufficient evidence to support reporting the diagnosis, like we talked about in a couple slides ago. So whether that's principal diagnosis or secondary diagnosis assignment based on official coding guidelines. And then just remember, a diagnosis must impact care in a way that justifies the inclusion in that coded data. So using AKI as our example, the KDIGO or KDIGO criteria is really the most widely accepted standard for diagnosing AKI. And when applying this criteria, this is what we use in our example. And your record review should include evidence of meeting clinical criteria, which includes one of the following that are listed there on the slide. I'm not going to read the 3 bullet points to you, but when you are determining baseline creatinine and it's unknown, KDIGO does recommend using the lowest creatinine value during that hospitalization as an estimate for baseline. And it's really important when you're applying this criteria that you note the 1.5 increase, 1.5 times baseline increase can be applied both retrospectively and prospectively. However, the greater than 0.3 increase is strictly applied prospectively because that denotes an increase and not a decrease. So that's often a confusion point for new CDSs when we're trying to validate AKI. And then in terms of things of what we're going to look for when reviewing for AKI, for clinical indicators and treatment and so on and so forth, a lot of times you're going to see some IV fluid resuscitation. You'll see serial monitoring of creatinine, and then you want to look for efforts to identify and to address the underlying cause. So was that patient given a nephrotoxic medication that's now being held? Does that patient have dehydration that's causing the AKI? Do they have sepsis or some other risk or related conditions? And then if you're in your review, if your lab values do not meet the established diagnostic criteria and there's a lack of treatment or clinical concern, that's going to be an opportunity for you to issue a clinical validity query. And for additional guidance, e4health has actually published a CDI tip sheet on AKI, and that includes some examples of applying the KDIGO criteria. And that might be a nice resource for you when you're clinically validating your cases. So as we discussed, we did identify several high-risk diagnoses that are reviewed of assessing for clinical validity. So now let's discuss how to effectively draft and present a clinical validity query. So these two examples on the slides are taken directly from the guidelines for achieving a compliant query practice, the 2022 update, and they're located in Appendix A of the query example section. So the clinical indicators that are included on a clinical validity query differ from those of a traditional CDI query. In a typical clarification, like for example, if we're querying for hyponatremia, we might cite findings such as low levels, treatment interventions like a 3% drip, and any relevant comorbidities to support the need for additional or more specific. However, in a clinical validity query, the goals shift slightly. While we're still aiming to ensure accurate and complete, the emphasis is really on determining whether the diagnosis is clinically supported by objective findings. So in these scenarios, the clinical indicators may highlight the absence of supportive data or conflicts between diagnosis and the clinical evidence that we're seeing. So if we look at acute respiratory failure as an example, as this is identified as a high-risk diagnosis, this diagnosis can be difficult due to the variability and how it's defined across institutions across the country. However, most still agree that patients with acute respiratory failure are going to present with some clinical signs of respiratory distress, such as wheezing, tachypnea, accessory muscle use, so on and so forth, along with blood gas impairment. And from a diagnostic standpoint, some criteria to follow in terms of acute hypoxic respiratory failure would be a PO2 less than 60 on room air, SpO2 less than 91% on room air, or a PF ratio less than 300 on supplemental oxygen. And for your acute hypercapnic respiratory failure, looking for a PCO2 greater than 50 with a pH less than 7.35 demonstrated on ABGs. So in the example being reviewed, for the clinical indicators, we want to make sure that we're getting the diagnosis we're attempting to validate and showing the physician where that's along with the absence of clinical indicators. So in this case, we have a diagnosis of acute respiratory failure, which is being in the H&P, along with, and the respiratory rate is 12, which a normal range is 12 to 16, and our ABG results reflect a normal pH and a normal PCO2 with no indication of hypoxemia. So these clinical indicators are really suggesting no evidence of respiratory distress or blood gas impairment, which is supporting why we're asking, for clinical validation of this diagnosis. So when we're structuring our query in terms of the query question itself, this is an area where there are two examples differ slightly. And your approach can vary depending on your organizational policies. But really, the guiding principle is to present a non-leading, clearly worded question that gives the provider a meaningful opportunity to clarify the diagnosis. I do want to point out that since respiratory failure has been done by a treating provider, it is compliant and it is okay to include that diagnosis in your query, such as, can you clarify the status of acute respiratory failure as in the H&P in progress note? When we look at the options that we provide physicians on a clinical validity query, the options, unlike traditional queries where the goal is to add or specify a diagnosis, clinical validation queries are really focused on either removing a diagnosis that's not supported in the record or obtaining additional to support the diagnosis if it is clinically appropriate. So in our examples, the answer options are acute respiratory failure ruled out, or acute respiratory failure confirmed, and then it's asking the physician to include the clinical indicators that they're using to support that diagnosis. And then we always want to make sure that we're including an other, please specify option to remain compliant with ACDIS and AHIMA query practice brief. So before we transition to our expert roundtable, I just wanted to leave you with a few key considerations and best practice tips to keep in mind. So first, education is always a foundational element, and education remains a cornerstone of any successful clinical validation process. So one of the most effective strategies when educating providers is really to emphasize the importance of the clinical decision-making process, including the clinical indicators and criteria used to arrive at their diagnosis. So this is not only going to support clinical validation efforts, but it's also going to enhance the accuracy and defensibility of their E&M billing as well. And it's important to recognize that diagnosis development is not always a linear process. Providers often begin with a list of differential diagnoses based on signs and symptoms, and then at the time of the initial patient contact. And then as diagnostic testing and clinical assessments progress, that should reflect the evolution from symptoms to definitive diagnoses, really highlighting the patient's underlying acute condition, comorbidities, and rationale for inpatient care. And both ACDIS and AHIMA really do reinforce the need for ongoing education, not only for providers, but also for clinical validation professionals, including CDI and coding professionals. And the second tip to keep in mind is the importance of substantiated diagnoses. So when you're reviewing a record, really all diagnoses in the patient's health record should be supported by clinical evidence that aligns with generally accepted diagnostic criteria. This just really ensures the integrity of the coded data, and it reduces the risk of clinical validity denials. And the third is organizational support and standardization. So as leaders on the phone, organizations can strengthen their clinical validation efforts by really establishing internal guidelines and agreed upon clinical criteria for high risk or frequently queried diagnoses. I really can't stress this enough. I think this is the biggest tip on here, is to get some facility specific clinical criteria in place. These guidelines can be developed collaboratively with medical staff, CDI specialists, coding professionals. And this standardized approach provides a clear framework for support, consistent decision-making, and it really promotes alignment across all stakeholders involved in the encoding process. And then lastly, AHIMA does offer several additional recommendations to strengthen the clinical validation process. And the first is critical thinking in a review, right? So when you're conducting your clinical validation review, as a CDS, you can ask yourself, would another qualified provider reasonably arrive at the same conclusion based on their review of the health record? And also consider, would this diagnosis withstand an external audit scrutiny? So if you ask yourself those questions, that might help you determine if you need to issue a clinical validity query. And then secondly, again, this might be more towards the leaders on our call today, but really establish clear policies and responsibilities and implementing formal policies and procedures that define who's responsible for performing a clinical validity review, who's authorized to issue the clinical validity query, and then how that clinical validity is considered during the coding process, particularly when a provider's response to a query conflicts with the clinical picture. So I know that was a quick rundown of clinical validity, but I'll turn it over to Stacy, who will lead us to our roundtable discussion.
Thank you, Allison. Appreciate that. And sorry for the glitches. I might be fired as Vanna, so I appreciate you bearing with us on that. But now it's my pleasure to welcome Debbie and Tanya. It was an absolute pleasure. I got to meet you, both of you, at the ACTIS National Conference, and thank you for your willingness to share your expertise today. And if you both would just describe your current roles and responsibilities within your organizations, and we can start with you, Debbie.
Well, I want to start, Stacy, by saying thank you for the opportunity to participate on today's panel. This is such great information, and I'm happy to be here. So I am a CDI educator for Providence Health and Services, Oregon region. And essentially that means I get to wear a lot of hats. So I am part instructor, part coach and mentor, and also a quality advocate for our team, which is made up of a combination of both new and experienced CDI professionals. My main focus in my position is really to support our team by helping them tell the most accurate and complete version of the patient story through the provider. This support is accomplished through a variety of approaches. Primarily, it's via individual chart reviews, otherwise known as audits, that I do for each individual on a quarterly basis and provide totally educational, non-punitive, one-on-one feedback, as well as education for the team as a whole. So I am on an ongoing basis, continually creating education materials for the entire CDI team, as well as our providers that reflect the latest in coding guidelines, clinical best practices, as well as regulatory changes. And one of the things I really enjoy most about my role is when I'm able to take a complex clinical or coding concept and break it down into something that actually makes sense to the team so that they can feel more confident and effective in their role.
Great, Debbie. And I definitely align. It's always just showing that true clinical picture for our CDIs. Thank you so much for sharing. And Tanya, how about you?
Hi, I also want to thank you and Vanessa for the invitation. Debbie, you have an interesting job there. So I'm the CDI manager for a health system in West Virginia. It's WVU Medicine. Our mothership, our flagship is JW Ruby. We have 763 beds there, a level 1 center, level 2 pediatric center. We have 25 hospitals in our system, but our staff is only reviewing at 9 of the acute care facilities right now for the inpatient team. Our team is comprised of RNs, LPNs, coders, and foreign med grad doctors. We have educator, auditors, analysts, project managers. We just recently acquired the DRG downgrade nurses to our team. We have level 3s on our team that have a project, and some of their projects would be like CHF readmissions, working with the physician advisories on escalations. Some of them work with DRG downgrades, pediatric reviews, and things like that.
Great.
It's my role.
Thank you, Tanya. And love hearing about everyone's different roles in organizations. And so if each of you could just take some turns about what are some of the most common pitfalls you encounter or your team encounters during that clinical validation reviews, and how do you address that challenge? And I know for me, those are my least favorite to write. So just share any of your experiences that you have with your team about clinical validation. Debbie, I'll let you start, and you're on my screen on the left, so
no
so
worries.
left to right.
We can move left to right. That's fine. Well, I think especially as I consider the newest members of our team, some of which I've recently finished orienting, I think just from the perspective of educating them to understand that it's not just about looking for what's not there and query opportunities, but kind of shifting their thought process from just because a provider is in a condition does not mean it is clinically validated for that particular patient. And understanding that, yes, when something is part of our role and responsibility as a CDI specialist to make sure that there is clinical validation and solid clinical validation for every diagnosis. But I think that, some of the recurring pitfalls that we most commonly see from my perspective really fall into three categories. I mean, the first one will come as no surprise, and it's really just lack of clinical support for the diagnoses. And I think that Allison hit it on the head with those 5 high risk diagnoses, because those are the ones that we see most commonly: the sepsis, AKI, encephalopathy, et cetera. Making sure that our team is doing the work to make sure, if it's AKI, for example, we adhere to KDIGO criteria to make sure it's met, whether retrospectively or prospectively, because the provider diagnosis isn't always going to align or adequate, it's not going to adequately be supported if we're not doing that. I think the second one is really overuse. And I know the providers really love their templated notes, but overuse of those that are copied forward, again, it's more of a convenience to them, but it can really lead to outdated or just inaccurate if it's carried through. I also like that Allison talked about just the evolving provider, for maybe where a diagnosis like sepsis is possible to where it's ruled in and ultimately resolved, hopefully by the time the stay is done. And then lastly, really the ambiguous or uncertain terminology. I know we've all seen terms like probable sepsis when the indicators are either weak or just not there, or CHF not specifying, if it's systolic, diastolic, et cetera. And my beloved AKI, with a question mark. Like, so those to me are like the most common pitfalls we see in.
Thank you, Debbie. Appreciate that. And I always want to say to doctors, you got to show your work, right? Like just like in our math. Yeah. How about you, Tanya?
It's interesting. Allison had the same ones listed as I did. Few additions, like type 2 MI now is kind of like on our radar. The consultant and the attending are differing all the time with them. Now, like with the type 2, is it ever going to, is it still, if they're readmitted, do you get to capture that like the type 1, in 28 days rule, so we've had that debate this week. Had the physician advisories last week point out to us, we ask them sometimes when we have acute respiratory failure, often by the providers, and, we query and try to validate it like we should. Sometimes we have to escalate that, though, because, the providers are not giving additional information. So the physician advisors said, it would really help, somehow in our templates or in our software, like we could see what baseline were they on, were they already on 2 liters? How am I going to, go peer to peer with this person? If they're on 5 liters now, that's all I see. What were they on, so that's one of the things that we're going to try to work on, in our to get, baselines and things. Sepsis, linking the organ dysfunction and getting payers and CMS on the same consistency, who's going to adopt, SEP 2, SEP 3. Malnutrition, we've created dot phrases. So our RD notes will pull into the provider's progress notes so that can help justify any treatment for malnutrition. That's been helpful. And AKI, of course, we see like cases where the creatinine hasn't changed for 3 days, but they're still calling it AKI, justifying those kind of things. But similar, as Debbie and Allison pointed out.
Lots of similar pain points, right? We're getting close on time, so I'm just going to have you guys both wrap up with any like hot tip, best practice, or tool that you've used with your teams to help with clinical validation or diagnosis selection. And then audience, stay tuned. We'll get to you to show how you get your Active CU. We'll wrap up with that question, and then we'll drop it in the link in the Q&A section so you can get if you have to leave for another meeting. But let's hear from Debbie and Tanya. Just a quick tip or best practice that you want to share with the audience.
I'll start. I just want to say start with the story and not with the codes or the diagnoses that are there. I mean, I really encourage the team to begin by looking at the full clinical picture. What brought the patient in? What was treated? What condition was it that ultimately drove the length of stay? And really, by doing so, it really anchors our thinking in the patient's journey, and it helps to avoid just straight into any coding logic instead of focusing on the true reason for that patient admission.
I love that. Start with the story. All of our patients have stories. Thank you, Debbie. Thank you for joining us. And Tanya?
Very good. Also remember, technology is just our tool. Timing is rolling it out. You want the team to build trust in the tool. And we're navigating through new waters with automated denials to the, payers and things. So that's something new we'll be watching. But, and since time has evolved since I started this, there's so many resources now for CDI and coding. Before, we went from the paper book, but now there's podcasts and webinars and all kinds of things. So never stop learning.
Never stop learning. I love that. And that's kind of always our motto. And so thank you both. Sorry to have rushed you, prepared extra questions, but just we're very insightful. Thank you. And now I'll turn over to Allison, and she'll wrap things up and tell you about how to get your free CEU.
Yeah, well, thank you, Debbie and Tanya and Stacy. And if you'd like to collaborate and learn more about how e4health can help your CDI program, let us know in the survey that you'll receive after the roundtable today. Our CDI service team wants to help your team do the best that it can be. And we are always looking to add top talent to our team. So if you're not a current e4health customer and you'd like to join our CDI services team, we have an amazing team that we're really proud of. And so that's also a question in the follow-up survey from today. And as you've noticed, we're passionate about CDI here at e4health, and we really have a vision of powering better health. And as we strive to meet our vision and uphold our values in doing so, our commitment to you and the CDI community, we're happy to share complimentary monthly CDI tips, continue our CDI roundtables. So be sure to follow us on LinkedIn and stay in the know with our customer newsletter. And if you enjoyed today's discussion and you're interested in another ACDIS credentialed webinar, we'd like to invite you to our next CDI Leadership Roundtable, focusing on CDI reconciliation as a strategy for quality, compliance, and financial impact. And we're taking this off and regrouping in the fall. So if you'd like to join us on Wednesday, September 12th at 12 p.m. Eastern Standard Time. And now the moment you've all been waiting for, we want to make sure that you get your free CEU that's provided to you by e4health. So to collect your CEU certificate, there will be a link to take an evaluation that's going to be dropped in the team's Q&A and the chat. And don't fret, this link will also be emailed to you after today's presentation if you don't see it in the Q&A. Once you complete the survey, you'll receive a link to obtain your active CEU certificate. And I just want to thank everyone for joining us today. We appreciate your attendance to all of our E4 events, and we hope you have a fantastic and hope to see you back in the fall.
Thanks, everyone. We'll leave it open just for a few minutes, and then we'll end the event. So if you want to grab that, and thanks, everyone, and have a great